Dr. Sisto, thanks for taking some time to speak to me this evening. Just wanted to take some time to get to know you a little bit better and to understand um, your journey into podiatric medicine, how you look at your practice and its growth and your evolution through your training to now how you manage your caseload, and talk about your experiences in managing ankle fractures and what's that's been like in your career, and on this case study that we worked on together, and help understand, you know, how you're thinking about the use of the flex thread, why this patient was particularly appropriate, and kind of how she's doing now. But yeah, welcome to the podcast. Tell us who you are and what you do.
Yeah, first and foremost, thanks for having me. I'm excited to be here and kind of have a stimulated discussion because, fractures and trauma, that's my passion, and hence why I kind of evolved into using so much intramedullary nailing because I see the clinical benefits. But yeah, I'm Dr. Sisto. I'm in private practice here in Mesa, Arizona. And so I'm originally from Minnesota, and so I obviously have jumped ship to much hotter weather and more, I would say, more predictable weather, and I'm loving every day of it so far.
Vikings fan or Cardinals fan?
Vikings fan, though I'm in a constant state of disappointment just by being a Minnesota sports fan in general. I tell everyone who comes by my office, they always ask me, "Are you a Vikings fan?" I'm like, "Yes, unfortunately, but I'm a diehard fan. I'm loyal. I'm okay being
It's a good
disappointed."
team, man. They had a good run last year. Interesting
Yeah,
quarterback choices, but it is what
very.
it is.
That's something we've never been consistent with. Everyone gets injured or they're old or something. So,
Or they get good and move on to a different team,
yep, that's how it
and
works.
get moved on. So
Welcome to Minnesota.
now in Mesa, tell me a little bit more about your practice, and kind of your split between call and trauma and elective cases, and in general, what you like to do and how you like to operate.
Yeah, I would say for the most part, I've evolved into the sense where now I'm taking more call just because I really enjoy taking call. I like the unpredictability and getting called whenever. That might not last a long time, but while I'm younger, I'm going to utilize it because you never know what can walk through the emergency, doors. So
Sure.
right now, I'd probably say 75 to 80% of what I do is just purely foot and ankle trauma. And so most of it is ankle fractures. I'm usually getting about 2 to 3 a week. On average now. And now since the snowbirds are coming out, this month and then the next couple months are going to skyrocket the snowbird population. That's when a lot of the trauma happens from pickleball and all those fun things. But it's definitely more trauma focused. So, I would probably say 10-15%, maybe 20%, and I'm being generous, is elective, and that can encompass anywhere from minimally invasive bunions to total ankle replacements, but yeah, majority of what I do is foot and ankle trauma for the most part.
Yeah, and like you mentioned, a lot of your practice is ankle fractures. How
Mm.
often are you seeing those in those kind of snowbird, more geriatric populations, and how often are you seeing those kinds of trauma cases in maybe younger, more active people?
Yeah, I would probably say the majority of what I do is probably the immunocompromised, maybe geriatric osteopenic bone. Just that's just how it is. That there's a higher population of older people here in Arizona, especially during this time before it gets too hot. Um, and then I'd probably say at least 75%. And so it
Wow.
tends to be, yeah, they tend to be more the complicated, and it's like these are low velocity injuries for the most part. I'm not taking
Sure.
calls at level 1 trauma centers where it's high velocity, and these tend to be happening from pickleball, mowing the lawn and they tripped in a pothole. They were chasing their dog type situation, or hiking. And so yeah, and you get every in a rare blue moon, I'll get like a healthy 18-year-old, and those are still the patients where initially I wasn't nailing them. It's because it was my old philosophy going back to residency and just my training, where those ones you can play, you can make big incisions because they have the capacity to heal, right? And I'm assuming we'll probably go into that later, how I've evolved. But yeah, for the most part, it's the the standard geriatric ankle fracture, immunocompromised, multiple comorbidities. That tends to be the most common one that I see.
Yeah, let's talk about that some more. I think that is a good segue. So, tell me a little bit about where you trained, and was that demographic fairly similar there? And, did that inform your implant choices as well?
Well, where I trained, so I did my residency in Portland, Oregon, at Legacy Kaiser. Phenomenal program, awesome faculty, um, big mentors of mine. I still am in communication with them. The surgical training up there and the volume was incredible. Probably one of the better ones in the country. And obviously, I'm a little biased, of course, but but we were associated with a level 1 trauma center,
Okay.
and so we would see more of the high velocity, injuries. I was lucky enough to work with a lot of the traumatologists too. My wife was an orthotrauma PA, so I made friends with him, the
Hmm.
surgeon that she worked for, and he saw a lot of the pilon fractures and the complicated, comminuted, segmental, multifragmentary injuries.
Yeah.
And, I fell in love with the principles. And the good thing was that everything was open. The Pacific Northwest, the culture, everything is mostly open. It was just the influence, the culture. And that is something um, that I was able to experience. And I think seeing everything open is very good when you're training, because you can see the anatomy, you can appreciate the anatomy, you can appreciate the reductions, you can ensure everything's anatomic, and then things kind of flow from there. I think that was a big part of the reason why I want to do fellowship, because I knew there was other options. I didn't want to be narrow-minded. Even though the surgical training was incredible, I learned a lot, and I have some of the best mentors that one could possibly have, but I wanted to kind of venture out a little bit and just get a different perspective.
Hmm.
And that's when I went to fellowship at University of Louisville. 6 months was essentially with sports medicine, you know, um, orthopedic surgeon, and then 6 months was with an orthopedic traumatologist. And so that's when I got introduced to the fibular nails. And you would see these patients post-operatively, and they just did better, right? And the
Hmm.
incisions were smaller, and so that's when I got my first glance, and I saw the clinical benefit. And so I think we'll probably go later on as to why I kind of shifted from those nails to the Conventus flower nail. But at least that's when I got my first exposure to minimally invasive surgery, when it came to bunions, when it came to bunionettes, but ankle trauma. That's something I never had when I was a surgical resident up in Portland.
Okay. Yeah, I mean, I know that you went with some interest to do some more of the soft tissue management stuff too. I mean, especially with those 6 months there at Louisville. So to go from that to seeing sort of maybe some of the lower velocity fractures and the transition into what you're seeing more frequently in your practice is it's cool. I'm curious as to with patients of those different presentations, are there conversations that you have from a expectations management standpoint that look different based on whether someone's coming in with a high velocity ankle fracture versus an elective surgery versus, a younger patient who's looking to maybe go back to activity sooner now that you have kind of seen the gamut of the different people that are coming into your practice?
Yeah, I mean, the conversations that I have now are definitely different versus someone who's young, healthy, has the best capacity to heal, the best protoplasm, the best biology, essentially, right? I get those elective, but again, that's a small part of my practice. The majority of my practice is the older population, and some are healthy, some are not. The majority are not.
Mm,
Um, but the ones that I typically treat, the ones with multiple comorbidities, I mean, those are significantly different conversations, and I individualize my treatment plan per patient. Everyone's different. Everyone has different comorbidities, and that all can determine the conversation we have preoperatively. But but those conversations are definitely, I say that people are more receptive there to the point where there's an option where we can minimize soft tissue trauma because of not only technique and training, but the products that are available. And so, now patients are able to get the surgery done earlier. They don't need a staged surgery. They can weight bear earlier. They are able to go to work earlier. They're able to get on their feet earlier. And those are all things that when I was in residency, I mean, these people were not weight bearing for 6 to 8 weeks. They had massive incisions. They had, significant hardware. And, in the majority of patients that I treat, being non-weight bearing for 6 to 8 weeks is simply not even an option. It's not. If it is, these are patients that get deconditioned really quick and their health is compromised. Here they are going to a skilled nursing facility, and that's where patients, their health plummets. So I do whatever I can to encourage these patients not to go to a skilled nursing facility. Sometimes that takes me to speak with case managers and the hospitalists who are admitting these patients. But anything I can do to encourage earlier mobilization and range motion is something I'm going to implement in my practice.
Okay.
And so far, the results that I have received have been incredible for these type of patient populations and cohorts of patients.
Yeah, it's understandable, right? Because I think you see the same experience in a lot of these same demographics after they have like a bad fall or have a hip fracture. So with more of the body's weight being borne by our feet and ankle, and just in general, I think lifestyle choices and the desire to be mobile when you can be versus not necessarily having the motivation to extend beyond your capacity at that point. You don't want patients to have a philosophical reason to be non-compliant on one end, or on the other end, completely disengage from any mobility or quality of life that they had prior to their injury. So, yeah, now that you are seeing more ankle fractures, tell me a little bit more about, that journey from starting off in training using more plates, doing more open reductions, to using nails in Louisville, and then your kind of journey in terms of implant choice and indications for each of those.
Yeah, so there's obviously, I remember just seeing so many hardware removals with plates, and the literature shows anywhere from 25 to 50%. That's across the board. And I have a traumatologist who would routinely remove the plates.
For what reason? Because
And
it had already healed, or
there's
because
mostly,
revision?
there's different. In residency it was different. Maybe the hardware was palpable, they could feel it, and it could change based on the weather pattern too. If it's cold, patients could feel plates more. And again, you have to understand too. the lateral soft tissue envelope over the fibula is not a lot. And when you put oftentimes these plates can be 1.5, 1.6 millimeters in thickness. Obviously, there's better plates now where it's anywhere from I think there's plates that are like 1.2 millimeters in thickness now. But regardless, that envelope is thin. It's prone to necrosis and tension, and closures can be difficult. So that's why you have to wait sometimes 2 to 3 weeks to even make these incisions, because you have to wait for the soft tissue swelling to go down. And so when I went to fellowship, and I saw these patients getting in earlier, their fibulas were getting fixed earlier despite swelling. Swelling's not even, I don't even think about swelling anymore, right? So it's because you can these nails, you can create a smaller footprint and have an equivocal result. We now know based on the research that as long as you have a good reduction of the fibula, it's out to length, alignment, and rotation, you can use a plate or a nail and you can have equivocal results. And a lot of studies suggest that you can have superior results based on, questionnaires and post-operative recovery and rehabilitation. They're on their feet quicker, because again, now we're talking about mechanically, these nails can be stronger from a biomechanical standpoint. Now you're talking load sharing versus load bearing, and so I kind of got off tangent, but, when I start seeing these in fellowship, you would see the clinical benefit, and you would treat these fractures earlier. But when I got into practice, I started kind of going away from nailing again, because I remember I was on the tail end of my fellowship and I was looking at x-rays. It's just something that I do. I'm kind of a nerd when it comes to that, because I was going back and I would think I was making a PowerPoint on I don't really remember at that time, but I was looking at these post-operative x-rays, and, though the fibula was acceptable, the alignment with these nails, I would still see some slight rotation and shortening of the fibula with a lot of these older nails, or these other nails that are available on the market. And I was asking myself why. And now, and I never, at the time, was introduced to the flower until I had a rep out here when I was in my first year of practice. And he's like, you know what? I understand your hesitation, because for the first couple months I was using plates again.
Okay.
Because I didn't like the radiographic results when I look back to my cases in fellowship. It didn't sit well with me. And so, but then the rep out here introduced me to the nail, and then I used it, of course, in your typical patient you would reserve a nail for, your immunocompromised, end-stage renal disease, dialysis, cardiovascular history, just poor. You never want to make an incision on this patient. I used that nail, and I was absolutely amazed by the simplicity and the efficiency of the case.
Okay.
Right. So this nail, we'll probably go into it again later, but it's substantially different than all the other nails. It's a straight nail, it's flexible, it's titanium. The instrumentation is seamless, it's easy, it's low profile. I mean, I could go on for days talking about the improvements and the I would say the superiority of it versus other systems on the market. But that patient, did extremely well.
Okay.
And that was me, despite making a 2-centimeter incision at the fraction and reducing it. I still do that with nearly all my fibulas. I make an open incision, I reduce the fracture, because again, reduction is key, and you cannot sacrifice a good reduction of the fibula. Otherwise, I don't care what you put in there. If the fibula is not reduced, you won't get a good outcome. So, but that's kind of how I've ventured now into the Conventus flower, just by simply utilizing the nail.
It makes sense. Yeah. And having that positive experience on one of the first cases in your practice, right? Like, I think, do you think it helped you that you'd done nails in Louisville before? What would you say was like the learning curve to going from plating to nailing initially, and then when you got to Mesa, like going back to nailing after you'd taken some time away?
Yeah, I mean, especially if you're formerly an open surgeon, nailing can be relatively challenging, not in the technique or the nail itself, but the fact that you're creating a smaller incision. So you might not be used to that. Your visualization is less, but it also depends on where you're making the incision. But for anyone who does any sort of nailing whatsoever, I mean, we do tibio-talocalcaneal fusions all the time with hindfoot nails. We do Jones fractures. So the learning curve is not nearly as steep as one would think. I think the hardest part about these nails is oftentimes, I'm putting the wire in initially, but I think everyone who does foot and ankle surgery, they have experience with other nails, not explicit to the fibula. So that's the hardest part, is that initial guide wire patient. But there's a bunch of pearls for that we can go into, but the learning curve is not a lot, especially if you've done open surgery before. You appreciate the anatomy more. Now where to place your incisions based on the fracture, the anatomy. Things are easier because you have a better understanding of the fundamentals and the principles. Those you can never negate. And when it comes to, and that by that I just essentially mean reduction and AO principles, those type of things I'm referring to. Those can never be sacrificed. Those you always need.
Universal things, right?
Exactly. Those are just simple universal things any surgeon will know. But again, when you having an option where you can create a smaller footprint in the setting of soft tissue trauma and get patients on their feet earlier and get to them earlier, now you can kind of go into the cost standpoint. That's
Sure.
another caveat of the system. Everyone thinks, yeah, it's very expensive up front, but I don't. For me, I'm going to be putting something in where it's patient first, and I think it's going to give the patient the best possible outcome.
Mm-hmm.
And ultimately, it is actually cost saving when you look at it. In the lifetime of this patient. Now we're not, going in for a possible subsequent surgery for hard removal. Maybe we're not staging it. A lot of these ankles sometimes, due to the swelling and soft tissue insult, you're putting them in a frame and then bringing them back 2 weeks later. And then if the plate is prominent, you're bringing them back in for a third surgery for removal. So these are things that I saw, and so from a cost standpoint, I don't think that's really even an argument.
Okay.
To be honest with you. But the main thing for me, the benefit of this is just creating smaller footprint and having something mechanically stronger.
Makes a ton of sense. I think the comment that you made about load sharing versus load bearing is a really important one. You see that kind of same result on the tibia, right? And being the heavier load bearing joint, it stands to reason that even if you have something like a fibula that's not quite as load bearing, but do it in a way that you're avoiding damaging any of the lateral soft tissues, you have a mechanism to uh, have a one and done, and hopefully have that patient reambulate more quickly and get back to their activities of daily living, whatever those might be, younger old patient. So
Absolutely. There's so many benefits. I mean, I could go in just a much deeper, extensive conversation just about the benefits of minimally invasive surgery, not necessarily nailing, but I mean, there's so many benefits, and so for people who have not implemented nailing and just minimally invasive surgery in general, I think that, it's time. And I think that's where foot and ankle surgery is headed. That's the evolution, whether you like it or not. But it's all for patient care at the end of the day, minimal soft tissue disruption, quicker healing. I mean,
yep.
how can you argue that? So, and this is the tool that allows us to do that.
Like, you're talking about the fact that the majority of your patients are comorbid, right? And I'm probably I'm guessing a lot of them are comorbid with diabetes or some sort of peripheral vascular disease that makes it difficult for them to reinnervate or sort of heal in an appreciable amount of time. Is that accurate?
It's accurate, but also even the patients that are healthy, they're older and they're bone stock, they're osteoporotic, or they have osteopenia to some capacity. These are injuries where, I mean, these fractures are comminuted, they're segmental. Those are ones where I would never even consider nailing. And then again, you do more and more of these, you continue to evolve, and then you start finding ways to reduce, but also maintain the reduction. That was the hardest part before with these other nails, is maintenance of reduction when you're implanting, right? Or even prepping the fibula for the nail, is maintenance of reduction is seemingly the most challenging part with these nails. That's the same case with femurs and tibias, is maintenance of reduction. I remember assisting the orthopedic surgery residents in fellowship, and here I am, they're prepping and reaming the tibia, and I'm distracting the leg the entire time and having a reduction clamp on the tibia trying to maintain. It's hard, and so with this instrumentation that Conventus has, it just makes things super simple, because the beauty of this nail is that you're not tamping it, you're not malleting it, you're implanting it like a screw, and it's precise.
Mm-hmm.
And it really is simple, versus what else is available on the market. So again, a lot of benefits.
Let's talk about that. So we know that you started by plating. I mean, obviously there's some cases where you're still having to plate, but your expansions or your indications have expanded because of your comfort level with the nail. Why did you choose to move away? What were you using initially? What concerns did you have about, that implant or instrument choice? And then what about the flower nail, is better for you?
Yeah. Awesome question, and hopefully I answered appropriately. But the other instruments I were using were fixed devices, stainless steel for the most part. It was just that's fine in and of itself. You can make it work. I think a lot of it was, but it wasn't reproducible.
Okay.
And what I found is these other systems, it's very challenging to maintain the reduction because of the fact you have to tamp it in.
Hmm.
And oftentimes, if you inappropriately reamed or you didn't ream enough, you're really finding the challenge because now you have to hit it really hard. And
Really hard
oftentimes,
for it. Mhm.
these distal fibula fractures, that distal fibula, it can be soft, it can be comminuted, and when you're tamping in a friable bone that's you know uh, that's prone to external rotation and shortening, you won't maintain reduction. And that's something that I saw with these other competitors. And now, of course, the more I do, there's more things that I do to, on top of me holding the rest. So when I make my incision for the fibular fracture, I will reduce it. I have at least 2 clamps on at any given time.
Okay.
That's just something that I do, and those clamps are on there until I put in the distal interlocking screws. They will never leave, and that will ensure that the reduction is maintained. And another thing that I've done now recently is in these comminuted fractures or these segmental fractures. Another thing that I've done is utilizing cerclage or number 5 fiber wire
Mm-hmm.
to put around the fragments, because oftentimes, when you are reaming for the nail, the fragments can become unstable and loose, and that can create a challenge. And now that I utilize these cerclage in almost all my ankles, the reduction is maintained, and I could easily take the clamps off because the cerclages are very strong. But again, they're just more point to fixation. It's another method that I've used to maintain the reduction. And then on top of that, the nail itself, how you implant it, you implant it like a screw,
Yeah.
and you can do it more precise. You're not forcing anything. Those proximal 35 millimeter threads, they come in 3-5, 4-5, and 5-5, depending on the anatomy of the fibula. They will grasp that endosteum, and you get excellent purchase, and it will guide you, in the fibula. And the good thing about this is the flexibility. And so sometimes you have these obscure fibulas, maybe abnormal morphology. It's flexible, so it's going to conform to the anatomy of the fibula and not the other way around like a lot of the other competitors. And so there's so many advantages to this nail versus whatever is out there, but just intramedullary fixation, generally speaking.
Has that made, one of the comments you made earlier is the in the learning curve of going from plating to nailing, regardless of what system you use, guide wire placement is sometimes a challenging component, right? Does having a flexible shaft and, the fact that it's conforming allow you to be more reproducible with where that entry hole for that guide wire is?
Good question. Yes, absolutely. So with the other competitors, you because of their fixed nature, they have this little slight valgus bend to it. Your starting point is critical. It is very, very important. If you're off, if you're not lateral in that distal fibular tip, you are going to automatically create a malreduction. And I think that was the biggest problem with a lot of the ones that we did in fellowship is, these are typically polytrauma patients. You're just trying to put it in, doing something quick, creating a small footprint. But, so that's why, I mean, if you're off on the starting point with these other competitors, it's going to be a problem. You're not going to get a perfect reduction. And again, as we know, you can't sacrifice reduction for a good outcome. In order to obtain a good outcome, you need to have anatomic, restoration of length, alignment, and rotation. That's something that's been borne out for a long time now. I think we all understand that if we do enough ankles, that's critical, that's crucial. So with a straight, flexible nail, you can be a little bit more lenient.
Sure.
Again, because this will find its path based on the morphology. And, and I think some of what Brian Kistler told me, when you actually look at a fibula on the mortise view, it's straight. It is a straight bone,
Mm-hmm.
and so trying to put a guide wire in laterally, it's not, it doesn't make a whole lot of sense to me. And you have those unique cases where maybe it is slightly valgus, but when you look at the fibula on a mortise view, it is a straight bone.
Sure.
And
And
I think straight instruments work better. It creates less malreductions. And now we understand that, these work, and they work really well in comparison. At least in my experience, I think the more we place these and the more reps we get, I think we'll start seeing the results, and the results will speak for themselves.
yeah, and we're starting to see, you and a lot of your colleagues post x-rays that just look beautiful, right? And starting to have a community of people that understand that what we were using nails for yesterday may not be as limited as what we can use them for today.
Yeah.
Um, specifically, you're seeing patients that are not just comorbid in terms of different pathologies that they present with, but also in terms of, concurrent fractures that they may have, or instability in other aspects of the joint. Like, how do you manage the syndesmosis in these cases?
Yeah, and a lot of them do. A lot of these come into the hospital, overtly dislocated, and clearly, I mean,
Mhm.
I don't even really stress the syndesmosis anymore. I mean, I know preoperatively just by looking at X-ray whether that syndesmosis is out or not. I mean, I don't remember the last time I've done like a cotton test or anything. I think a lot of that's archaic. I think it's important for training and testing, but when it comes to the real clinical, side of things, it's you kind of know when you do enough of these, you just have a good idea. I think the one time I will do some sort of stressing, it's an external rotation test in the OR, and that's after I fix a deltoid or something where it's more of like a subtle, less overt instability. And I'm really kind of deciding, is the syndesmosis unstable? Then I start doing some stressing. But then again, I have incisions. I'm looking directly at the syndesmosis. I can see, or I'm doing a scope, and I can do it. I can evaluate the syndesmosis that way with a positive drive-through sign. There's enough evidence on that now. So usually, if for those subtle ones, I'm looking at it overtly, and I can determine. So stressing is not really something that I do as much anymore. I still do sparingly, but it's becoming less and less. I think direct visualization is crucial. But if it's old, the kind of geriatric osteopenic bone, they're all getting screws.
All of them. Okay. Yeah, makes
All of
sense.
them are getting screws. I've noticed now too many times a lot of these osteopenic geriatric fractures. You have the tension, and the medial button is relying on that medial distal tibial
Mm-hmm.
cortex. And and it's soft bone, it can essentially subside, and then you can lose reduction of the distal tibiofibular joint, and that can be problematic. So all these patients are oftentimes getting one or two screws. It again depends on the patient. Are they obese? Are they neuropathic, diabetic, etc. But they're all going to be quadricortical. There can be four cortices every time, just in case maybe I have to remove one later. And I have a problem removing it. I can access it medially, and it's prominent, and it's more stable. You're relying on four cortices versus three. And the younger patients, sometimes even middle aged, I use flexible fixation. I think preserving the joint can be important, and maintaining mobility is important. And we now have, I think we all know the literature on flexible versus solid fixation. There's superior outcomes functionally, and we see that. Especially in athletes and in younger patients, middle aged. I mean, I've gone to the point where, depending on the patient, if they're middle aged with no comorbidities and they're maybe overweight, I'll do a hybrid. I'll put in a screw and a tightrope, and if I have to remove the screw at a later date, I maintain the tightrope, and so that they still have some sort of stability at the syndesmosis. So it's definitely a case by case basis, but I guess with the patient population that I see, for the most part, they are getting screws.
In those circumstances, where you're doing maybe flexible fixation or a combined approach, which of the syndesmotic holes are you using? Do you have a preference or rationale for that?
Yeah, and then it comes down to, the closer we get to the joint, we know it's more stable.
Okay.
But then that also, you have to think about, yes, it's closer to the tibio-talar joint, and it might be more vulnerable to fracture. Then is it intra-articular or is it extra-articular? I think that, there has been some research on, you go through the joint itself with a screw or a tightrope, and I don't think that really compromises results long term. But really, when it comes down to, if I have to, I will place it in the most proximal screw hole if I'm doing one. Just because in theory it's more stable because we're closer to the articulation,
Mm-hmm.
and of course we're always trying to put in implants that's the most stable, and placing screws in a position where they're going to provide more stability.
Yeah, that makes a ton of sense. End cap or any sort of prevention of fibrous ingrowth, is that something that comes up for you?
I mean, I probably say 99% of the time I do not use an end cap. I would say maybe the one time I would is if I want to use because these nails come in 130 and 180. If I don't want to use a 180 and I want to use a 130, but the fracture is in a peculiar location, and I really have to maybe put it more proximal than I would. It's now I'm burying it. Then I would probably put in an end cap in that case. I think I've maybe done it one time. But I will tell you that it's rare, and subsequent removals are not that challenging, and there's pearls for that too. I think an end cap is not, it's not as important like for a hindfoot nail.
Sure.
The calcaneus, it grows, it forms this barrier, causing hardware removals to be kind of challenging without an end cap. But I haven't run into that now, and I've had to remove maybe 3 or 4 of them now. A couple of them just because patients wanted their hardware out just because. But removing them are not challenging, and so I find end caps not really necessary, but it is an option. It is an option.
So, you talked a lot about reduction and the importance of getting your reduction right. Do you have any other surgical pearls for us as far as, your experience with the flex thread?
Yeah. Definitely implanting it is, especially in the beginning, because sometimes it can be the most challenging part, is utilizing intraoperative fluoroscopy when you're putting the wire. It is so critical, and just putting the distal tip and get an AP and lateral, because you can get a pretty good idea at that point whether or not you're good. And if you're not, again, the good thing about this system, everything is in one tray.
Mm-hmm.
There's a parallel guide that if maybe your wire is too posterior, it's too anterior, you can use the parallel guide and you can place it more, anterior, posterior, depending on where your initial wire is. And so you're not making multiple holes with the same wire, right? Because that can make things challenging when you do that. Then you'll never find, your perfect path. There's also a fracture finger that you can utilize. There's a lot of different things that you can utilize to ensure you have good wire placement. I think that's something that's really good about this system. I think the parallel guide is one of my favorite things to use, and I use it almost on every case where my initial wire placement is not right. But the fact is, it's when you make a 1.5 to 2 centimeter incision, you can look into that incision, you can get a really good idea of where to put that wire in the sagittal plane. And so typically I'm not using that parallel guide as much anymore, because I can look at it from multiple views to ensure that my wire is going where it needs to be. And then I think, sometimes trying to find the wire and placing it into the proximal segment can be challenging sometimes, just depending on the nature of the bone. And that's the other beautiful thing of having an open incision to fracture, because sometimes it's maybe going lateral medial to the proximal fibular segment. Good thing you do, you remove the clamps, distract, get a little curved hemostat, and guide the wire into the proximal segment that way. If you're still having problems, you can drill the proximal segment with the reamer, like a 3-2 reamer. That way you create a path for that wire to go into the proximal segment. Again, you can all do this through a 1.5 to 2 centimeter incision, because that's what you make to reduce the fracture typically. Those are my biggest pearls when it comes to reduction is in wire placement. You have more opportunities to make sure things are perfect when you're open. And it's usually never a challenge to reduce, because I'm usually getting these fractures within 1 to 2 days now. And so they're very mobile. And then, of course, I've already alluded to previously with cerclage now.
Yep.
It maintains reduction for you. It's super easy. I have a super easy technique. It takes me about 30 seconds with the number 5 wire or number 5 suture tape. I make a luggage tag, and I put a couple hand ties in there. I use 1 and 2 of them almost every single fracture now, because it doesn't take any extra time for me, but it maintains reduction, and it's another point of fixation. There's probably more pearls, but usually usually when it comes to when we're talking about kind of maintenance of reduction, and guide wire placement, those are probably the most common questions I get with nailing, because those are difficulties with other systems.
Sure. That makes a lot of sense. And the last question I have for you from a surgical perspective before we move to some of your post-op management stuff is, what do you do as far as feeling comfortable that your fibula is out to length? And kind of secondary to that, you alluded to earlier, when you don't want to use a 180, you might bury your 130 further. To what degree do you tolerate burying the implant versus having it kind of flush to the cortex, and how do you make the determination of where to put that implant?
Yeah, I think it just depends on, the level of the fibular fracture. If it's, I'll treat any fibular fracture up to like the mid diaphysis. Anything more proximal than that, I think, the risk outweigh the benefits. And usually then you're just treating the syndesmosis in isolation at that point. But I may have put in maybe 1 or 2 180s. It's relatively a rare time where I'm putting those in, because it's just the anatomy of the fibula. It tends to be very cortical, then cancellous, and then very cortical again. And, yes, in theory, there's a higher working length, but that creates more flexibility. And so, it really just depends, because I want a stable construct. I don't want as much flexibility, even though they heal. That's the one thing I've noticed with these nails. You're not really disrupting the blood supply. I'm maintaining the hematoma. They heal much quicker. But it's probably going to be one of those more mid-diaphyseal fibular fractures where I would consider a 180. Where, I'm not going to be burying the nail, 1 to 2 centimeters in the bone at that point, and put an end cap. I think, that just doesn't make sense. And so those are the mid-diaphyseal fibular fractures. I'm probably more so going to be targeting a 180 versus a 130. But definitely anything distal to that, it's going to be 130 for sure.
Are you ever over reaming and trying to, plug or graft proximally before you place that nail?
No, if anything, I'm usually under reaming.
Okay.
I use a 3-2 drill, which is so the flower has a 3-2, 4-2, 5-2 drill, just for the 3-5, 4-5, 5-5 nails. But I found that when I under ream, I'm able to get more endosteal engagement with the proximal threads, and so in theory, to me, I'm able to engage more endosteum, and that's going to provide me with more intrinsic stability of the nail. Now, there are those situations where I have gone up to a 4-2 just because it's a younger patient, and you have to. There's no way you're going to put in a 3-5 nail in those cases, because you need to ream to ensure that nail will grab and the nail will go into the bone, because it's a blunt tip, and so sometimes you don't want to force anything, because that again can cause inappropriate malreductions, but it's rare. I think for the most part, you can just do a 3-2 drill and you can put in a 5-5 nail, especially in softer bone. I've never had a problem with that whatsoever.
Yeah, you just get more interference if you need it, right?
Exactly. And usually the 3-2 drill gives you enough tactile and proprioceptive feedback. The more you do these, you kind of know, okay, I didn't get any resistance. I'm probably going to use a 4-5 or a 5-5. If it just goes in like nothing, I'm probably putting a 5-5. If I'm getting some resistance but minimal, I'm putting in a 4-5. If I'm getting really good resistance, it's going to be a 3-5. And so these are things, the more you do, you just have a better inclination as to what size diameter nail you're going to use. And so that comes with any system, you learn more the more you use something, and then you adapt and you evolve and you become far more efficient.
Yep. I just need to get the reps in and the comfort level up, I guess.
Exactly.
Kind of similar to your journey from Louisville to Mesa. So rapid fire here. Post-operatively, have you seen any changes to how you're dealing with pain management and narcotics?
Yeah, no, that was one of the things where I didn't expect to see a change. Just because these are still trauma patients, they do have a traumatic insult that's oftentimes you can't see, a soft tissue component you can't see, and these trauma patients tend to have more pain than elective patients. But I can tell you one thing, I don't use tourniquet. I haven't used a tourniquet in 3 years. My incision's smaller, so in theory, that's less surgical insult, less surgical trauma, less pain, less periosteal dissection. There's just less dissection, less swelling, less bleeding. And so I have 100% seen less narcotic use. I used to routinely send 5 patients on 5 days of narcotics. Now I do a day. And at their first post-op follow-up, they may have used 1, maybe 2 after their regional block has worn off, but then they throw the rest out. Now, is that the nail? Is that the smaller footprint? Is that the no use of the tourniquet? It's probably all of them, but I do not prescribe nearly as much pain medications anymore.
Yeah, that's
particularly narcotics.
Yeah. And kind of along the same vein, you've alluded to the fact that because there's less pain, they're able to mobilize more effectively. What are the changes to your, kind of weight bearing protocols or your time to weight bearing that you prescribe now?
Yeah, I mean, for the most part, if it's your standard bimalleolar or trimalleolar fracture, they're weight bearing in a boot right away. Now there's caveats to that, like anything. Sometimes you just have to still appreciate anatomy and biology. So if there's an equivalent fracture, whether we're talking bimalleolar or trimalleolar equivalent fracture, and there's isolated deltoid injury, they were repairing a deltoid at the same time. They're usually not weight bearing for 4 weeks because you can't speed up physiology. Sure. Tendon to bone healing or ligament to bone healing. And so I want to try to not disobey basic physiologic principles when it comes to ligament healing. So if I'm doing a concomitant repair of a deltoid, they're non-weight bearing for 4 weeks. If it's a pilon fracture and I'm using the nail, which is our case study, all pilons are at least non-weight bearing for 6 weeks. That's pretty standard. Diabetic patients who are neuropathic, I tend to be a little bit more aggressive now than I used to, but I'm still quite conservative for the most part, even though this is a load sharing device. You can't trust the neuropathy. So that I still try to keep them off it for at least 6 weeks. But then maybe we can be more aggressive physical therapy because of the implant. But for the most part, though, if it's your standard, bimalleolar or trimalleolar ankle fracture, I mean, they're weight bearing day 0 in a boot, and I have seen no issues with loss of reduction or failures. My failures have been in diabetic neuropathic patients. Okay. Those are the 2 that I've had to revise.
In instances where a plate wouldn't have necessarily been appropriate for, similar soft tissue and wound issues, right?
Correct. Yeah.
Last question for you, as far as follow-up is concerned. Any changes to when you're seeing the patients in follow-up or how you're administering antibiotics post-op?
Yeah, I mean, I just do the basics, skip protocol when it comes to antibiotics. They're all getting their dose preoperatively or intraoperatively, depending on the anesthesia preference. But my post-operative protocol pretty much stays the same. And when I'm seeing them, it's 1 week, 2 weeks, 6 weeks, 3 months. The diabetic patients I'm typically seeing for routine care anyways. So I'm seeing them every 3 months for the most part. If it's a standard patient, I'm still seeing them annually.
Okay.
I like seeing my patients annually just to kind of see how they're healing, how they're doing. And to be honest with you, most of these patients do not come back. They're
Not the
like,
same group.
I mean, I've had patients come back in 1 year and they're like, why am I here? But it's just nice to hear patients' feedback too. I mean, I've had a patient who had an ankle fracture on the other side. They played it, and they're like, "This is an incredibly different experience in a good way from them because we did the nail on the other side." You do enough of these, you have those patients where they were in the unfortunate situation where they fractured both their ankles. One was 10 years ago, one was now, and they're like, "This is incredible. I wish this technology was available then." But yeah, no, it's pretty neat. It's pretty neat. My practice has changed almost 180, and I don't really see myself turning back.
So what are your counter indications, if any?
Oh man, I think maybe a couple years ago I would have had a lot more than I do now.
Sure.
Obviously your proximal fibular fractures, your maybe your Mason. I mean that goes without saying. Before I would say segmental fibular fractures, multi-segmentary, comminuted. But now, again, I'm not afraid to make my incision bigger if I have to. Again, there's no underlying plate, so wound complications in my practice are almost. I've had one wound complication, and that's from a patient who went to a sniff and they got no wound care, and they came in and I could see their entire distal row of distal interlocking screws. That was one of the removals, unfortunately. It's rare. You make big incisions sometimes. You have to get the fibula perfect. They heal. When there's no underlying plate that's creating tension on the overlying soft tissue envelope, they heal. And so now I've broadened my indications to segmental and incomminuted fractures. When would I not use a fibular nail? Man, I would guess I would say like recently I had to do a revision on another nail that failed. Obviously, I'm not going to put another nail in, and so I plated that one. I mean, there's a contraindication for that, but
You're looking for reasons now,
I
basically.
am, and at this point, again, the more comfortable you are, you find less and less, and so yeah, that would be my one contraindication. Likely is if another nail failed, I'm not going to put another one in because I think that just doesn't make sense. I'm not going to put the same thing in the first time, even if the nail didn't fail. There's a big void there, and I'll fill in with bone cement and plate it. Yeah, that's something that I could probably.
And as long as you keep in mind the holy grail of fracture reduction and appropriate alignment and getting the fibula out to length, if you can achieve those three things in the distal part of the fibula, you're pretty comfortable putting a nail in.
100% of the time.
Yeah.
Absolutely. Yeah. I mean, you probably asked a traumatologist for segmental femurs. What are they doing? Are they plating? The answer is probably not.
Probably not, right? Yeah.
And here we are talking about a fibula, and people, are putting in plating because it's segmental. I just don't think that, that's a valid argument anymore. And obviously, we could have a cordial discussion with someone who thinks that that's inappropriate. But I'm getting good results and I'm more comfortable with it now. So I think the more comfortable you are with a certain product, you find new indications for it, and when the results kind of speak for themselves. And so I've been super happy, and my patients have been happy. And at the end of the day, patient care, it takes priority. So like all of us who do surgery, patient care is priority. So.
Well, tell us a little bit about this particular patient. So you had a 24-year-old present to your clinic. Walk us through, what was the nature of her wound, how she looked when you saw her and why you decided to do the flex thread on this patient.
Yeah, so this is a young, healthy female. This is a rarity in my practice, but this is a pilon fracture. She came in, with some pretty significant, soft tissue edema, to the point where, I was definitely not comfortable doing this acutely. And most of the pilons that I get, I mean, I'm not doing them acutely, and I think that's just unreasonable. Especially when there's displacement. The best thing to do in these situations, I think this is a phenomenal indication to do, a delta spanning external fixture, allow the soft tissue to stabilize, get the fractures, distracted, get everything out to length, and then get a post-operative, post-reduction CT scan to give you a much better idea for the fracture anatomy and to essentially guide your second stage.
So tell me what you're looking at here.
So here we're looking at, intra-articular type B pilon fracture. This is a kind of like a three-part injury. There's a posterior mal, there's a medial malleolar component, then you get the anterolateral fragment with the associated fibular fracture. And so this is kind of a challenging injury, but you can tell based on the CT scan, the coronal here, that everything within the external fixture, the fracture anatomy is actually lined up quite well. It looks near anatomic, and so that's another reason why I like the external fixture, because it makes the second stage much simpler.
Mm-hmm.
And so this is a fracture where I know that I have to probably make a small incision medial. I need to make an anterolateral incision to place an anterolateral plate. I'm not going to make a big posterior lateral incision based on surgeon preference. I think the soft tissue envelope, there's likely not enough skin bridge to do that, but there's no need to do that when you can make a 2 centimeter incision, reduce the fibula like you can with the plate. I mean, the only reason why we're making a big incision for a fracture like this, if we're using the plate, is to put the plate on.
Sure.
So if we can make a smaller incision and reduce the fracture and create a smaller footprint in a patient where there's already a massive anterior incision, I'm going to do it. And so that's what we did here.
Yep. So we go down, we can actually see what her, pre-op x-rays look like here.
Mm-hmm.
Or sorry, her post-op x-rays look like, day 0.
Mm-hmm.
Talk us through. So when you approach this patient, did you treat her fibula first? Did you treat her tibia? What are the considerations in managing that pilon that carry over to the use of the nail?
Yeah, for sure. And then this is a good question too. I mean, some people ask me, well, you could have, fixed the fibula at the time of the external fixture, but she was just so massively swollen. I just didn't want to compromise anything, to be honest with you. But you very well could with the nail. But the thing is with me that this is also, I believe, at 10 p.m. at night too. I just wanted to put an Exvix-on distractor, and and that's just the reality. But you absolutely could, and I'm sure she would have healed just well, because now you're looking at a 2 centimeter incision. But if you don't get perfect anatomic reduction of the fibula, that can destroy you for trying to reduce the pilon component at the second stage. And so I just decided to do it, at the second stage. I actually, in this case, I fixed the tibia first. Yep. With a very low threshold to fix the fibula first, because sometimes that can aid with your tibial reduction. But I had no issue. Fixing her fracture and getting everything anatomic on her tibia. And then I just wanted lateral column fixation. I think her fibula was pretty out to length, but I wanted to incorporate some extra stability, increase lateral column fixation in someone who's young, and provide her the best chance of healing. And that's what we did. So I fixed the fibula after I fixed her tibia. But you could easily fix her fibula first if need be. It just kind of depends. And sometimes that's an intraoperative decision that you're making as well.
What are you asking to be brought to that case?
Pretty much everything. So my rep now knows that, they always have plates available for the fibula if need be. That's always a kind of a plan B. Just in case something maybe fractured, maybe you blow out the cortex. Again, that's so rare. But this is we have every plate available. We have, and a lot of these ankle trays, they have so many options regardless. But these are cases where I also have graft available. You have kind of everything available to encourage and permit quicker healing in these patients, but you always have backup plans just in case.
And look, she looks great post-op. Seems like she was able to also, heal fairly well, with no remarkable complications or um, issues, and was able to get back to work, right? So,
Yeah,
um,
yeah. These
not a
pelons,
younger patient.
I have them come back at usually 3 months and then 6 months and then at 1 year. She never came back. I think we called her. I had called her. The reason I knew she went back to work full time because I had to sign some documentation for that. And I called her. I'm like, "Are you sure? Are you doing okay?" Because she's a teacher and she works on her feet 10, 12 hours a day chasing little kids around. So I wanted to make sure that she was fully good. But after therapy, we started therapy I think at 2 weeks,
Sure.
because we removed the sutures at that time, and she was doing great. But yeah, 4 months she was back to work full time in a trilac ankle brace, doing extremely well. And so I wish I would have her 6 months, but she's doing great. So
Yeah, the no news is good news here, right? So awesome. Well, thanks for sharing this with us, Dr. Sisto. I mean, it's a deviation from generally what you see in your practice, but I think it's kind of cool to see, the pilon being addressed at the same time, how that factors into considerations for how you use the nail. And then in general, I mean, when you go up and you see this, you can see some sort of the anatomic conformance of this more proximally, and what it's done for your ability to go kind of straight on as far as your approach is concerned with the guide wire and the implant placement. So a
absolutely.
lot of what we talked about that seems to inform your implant choice. It seemed like
Yep.
it it came in handy for this particular scenario.
Yeah, it just increases the possibilities, and by doing so, you're creating a smaller footprint, and you're, in my experience, improving clinical and patient outcomes. And it's revamped my practice. I think that for people who are doing a lot of ankle fractures, they try this, they implant it one time, you realize how easy it is, and it just this light bulb. It's me and distributor have a joke out here in Arizona about, like, the archaic implants. I consider plates archaic. They still come in utilization, but for the most part, they're archaic. But it's like driving a dump truck versus driving a Ferrari. It's just a seamless, efficient implant with proficient instrumentation that allows this surgery to be done in a timely manner, and it's truly incredible. And you have to do it to actually realize it and feel it. And, having that tactile, that proprioceptive feedback is so critical, for to change one's mind. Because yeah, you can see the evidence, you can see the research, but until you actually do it, that's usually that's the limiting factor.
Sure.
And then it's pretty common when people do it, they're like, wow, this is incredible. This is incredible. And so I'm super happy with it. It's changed my practice. Like I said, 180, and I'm super, super thrilled.
I'm glad to hear that, and glad to see your experiences with it, especially for your patients too, being able to do things like get back to work unencumbered. I mean, I think that's kind of what we make these products for. So
Hmm.
thanks for sharing with us, Dr. Sisto. And and before we go, like any shout outs, any people that you want to mention here through your journey.
Yeah, I'll probably raise his ego a little bit, but I will admit, Nat, who's one of the distributors here in Flower, I have to kind of shout him out because he's the first one that introduced me to this nail. He's the one that kind of brought me back into fibular nailing. I always knew for the longest time that fibular nailing had its place in foot and ankle trauma, but I just didn't like the other nails on the market, mainly for shortening and malreduction. And he said, try it. I tried it, and I haven't looked back since. But it's just obviously all my mentors, of course, from residency and fellowship. They're the ones that taught me. They're the ones who gave me the surgical tools to do what I'm doing, and never disobey the principles, and always obey AO principles, and understand the importance of reduction and these things that matter. And you can do anything as long as you have anatomic reduction. You can achieve phenomenal results. But how can we employ techniques and instruments to get patients on their feet quicker? If we have the instrumentation and the implants to do it, which we do now, I'm going to implement it. And so this is just an awesome implant, and I'm looking forward to the future of what the world of foot and ankle has for us.
Well, I don't think we could have ended that any better. So thank you, Dr. Sisto, again for your time, and for taking the time to put the case study together as well.
Absolutely. Thank you for having me.